rounds, co-sponsored by the University of Colorado Hospital and the Center for Bioethics and Humanities. Welcome indeed to this discussion of a very important topic, ethical issues in blood product shortages. Please, if you have questions or comments, please put them in the chat. It is recorded, so it's going to be available to your colleagues on the Center for Bioethics website. And just a preview of coming attractions. Next month, April 13th, we'll have a discussion, myself and Dr. Heather Straub, on ethical issues in a post-war Roe nation. So regardless of where you fall in the debate about abortion, there's a serious need to pause and think about the implications. I'm a philosopher ethicist and co-direct our Ethics Consult Service, Jackie Glover, with Dr. Kristen Ferfari, and Dr. Heather Straub is an MFM a faculty member and member of the Ethics Committee. And so that's coming attractions next month in April. But our topic for today is ethical issues in blood product shortages. And we are very pleased to have two experts leading our dialogue, Dr. Nicole Draper, who's the Associate Medical Director of our Transfusion Services at the University of Colorado Hospital, and also an Associate Professor of Pathology. And joining Dr. Draper is Dr. Joel Kniep, who's the Assistant Medical Director of our Transfusion Services and Assistant Medical Director of the Bone Marrow Transplant Apheresis collection facility at the hospital, and he's an Assistant Professor of Pathology. Take it away, Drs. Draper and Kniep.
Thank you, Jackie, for that kind introduction. Dr. Draper and I will be switching off throughout the presentation, but I will get things started for us today. The objectives that we're going to cover, we're going to identify causes of blood product shortages. We will identify ethical issues that arise when there are blood product shortages, describe an ethically justified procedure for addressing blood product shortages, and identify resources for addressing blood product shortages in individual cases. Why do we need blood products? This was a study that was done on patients who had surgery and refused blood transfusion. As you can see, the lower the hemoglobin, the less days they survived from until death. There is a high immediate risk of significant morbidity and mortality due to severe anemia, and so transfusion of red cells are needed. A little bit later, we'll touch on are there alternatives to that, but generally, oxygen carrying capacity is something that is vital, and there is a point of no return that you can pass. These are the total transfused products at University of Colorado Hospital. On a given month, usually around 43 to 4,400 blood products in total. That can vary from month to month based on traumas, different surgery types, but that's about an average for us. So product determinants of shortage, so you can have high demand, O-negative red cells would fall into this, or shorter storage time. This is where platelets with an expiration time of 5 days would fall into that. So we can and do have shortages of both those blood products. We've had shortages of cryo and plasma as well. Supply chain determinants of shortage. So any of these elements could lead to shortages, and during the pandemic, all three at one point in time did cause shortages of blood products. Initially during the pandemic, when we were at the stay at home, donors weren't coming in because they did not want to They wanted to be safe. They did not want to get stopped because people were not supposed to be out on the road. And so measures had to be taken to allow those people to come in and donate. Also, collection staff, as many people quit, retired, or changed jobs. Being able to collect 6 or 7 days a week was not always possible. There also were some testing issues, which Dr. Draper will touch on a little bit more. Transport, same thing. If there are shortages of couriers or even weather conditions, which would not allow the transport of blood products from donation centers to hospitals. Any of those factors could prevent or significantly delay the arrival of products to hospitals. So how often do you think blood products are in short supply? Only during pandemics? Once a year? Once a month? Once a week? Or every day? I think the answer might surprise you because the answer is every day. We are always in shortage. Sometimes they're critical shortages, sometimes they're just regular shortages, but there are predictable ones and there are ones that happen without notice. So this is from the state of Minnesota, a strategy for scarce resource situations. You can see that several of these we have starred, and these are actually things such as limit the use of O-negative red cells to women of childbearing age, use O-positive packed red cells for emergent transfusion of males. We don't do this just in situations of scarcity. These are things that we do on a daily basis. And so actually, if we look at these, 10 out of those 19, we're doing on a daily basis. That is blood bank standard practice for us. So we were ready. We were ready. I will let Dr. Draper go into the next section.
Musical chair. Okay. So to understand some of what we do and what the ethics are behind our decisions, we need to be on the same page about some basics about blood products. So what is the real issue when transfusing blood products is that these nice red blood cells that we may want to transfuse to someone else have all of these things sticking out on their surface that can be antigens for the immune system to see as being different or non-self and respond to and make antibodies against. And these, there are varying degrees of differences or heterogeneity in the human population between these. Some of them are very, very, very common. Almost everyone is the same, but many of them have at least 2 differences. And they also are different in how immunogenic they are, right? We know that some things are very likely to induce an immune response, and some things are much less likely, and you will have to be exposed to it multiple times or to a very high dose to induce a response. And so 2 of the most immunogenic are the ABO antigen, which is a carbohydrate that sticks out on the surface of the red cell here. And really what determines the 3 different options you can have, either being type A, type B, or type O, is a single sugar on the surface. So that's it, 1 sugar on the surface here. Whereas our H, which is another very immunogenic antigen that we proactively try to match people for, you can see this is an integral membrane protein. So here you either have this protein or you don't have it in most cases. So people are just either Rh positive or they're Rh negative. They either have the protein or they don't have the protein. So for ABO, we have 4 different blood types based on that carbohydrate that you express or that sugar that you express. So you can just express A, B, you can have a combination of A and B, or you cannot express either and be O. And these carbohydrates, they're called naturally occurring antibodies. We make predominantly IgM type antibodies to these carbohydrates that we don't have, right? Something that's different from us. Even though they're called naturally occurring, we aren't born with them, right? There is an immunizing event, but it's not exposure to red cells the vast majority of the time. What it seems to be is that there are bacteria that when our gut gets colonized, our throat, our colon, with these gram-negative bacteria, they have carbohydrates on their surface that are similar enough to our ABO carbohydrate that it induces us to make an antibody against what doesn't look like us, right? So for example, I'm blood type A, and so I'm going to have the A antigen on the surface of my red cells. Therefore, when I get my gut colonized, the bacteria that look like me, I'm not going to make an antibody against, but the bacteria that have the B on their surface, I am going to make an antibody against by 4 months of age. And so of course, after that, if you transfuse me, right, with antigen from a person who has B, the antibody is going to bind and I'm potentially going to have a transfusion reaction. So O, because it doesn't have A or B on the surface, those red cells could be given to anyone, right? And then of course, we sometimes want to transfuse plasma. So the plasma has the antibodies in it. And since the AB person doesn't make either antibody, then we preferentially like to have their plasma to give to people because we don't have to worry about it being ABO incompatible. But you can see, right, AB is only 4% of the US population. So getting enough AB plasma to give out to a lot of people when only 4% of the population is that blood type is going to be very difficult. O is the most common, then A, and then B. All right, so if I am blood type A, and so I do somehow get transfused or exposed to B red blood cells, then that antibody would bind. It immediately induces intravascular hemolysis, which means that the red cells get attacked by the complement and the immune system. They actually get holes made in them. They get broken into pieces. We get red cell fragments. We get microvesicles, which are very prothrombotic. And so the hemoglobin, which was nicely packaged in red cells, now gets released. So your plasma goes from looking, this nice straw or yellow color to being full of free-floating hemoglobin. And free-floating hemoglobin is very reactive. It scavenges up a lot of things and reacts with a lot of things in our blood. I'm not going to go through the details here, but basically it can lead to widespread thrombosis, DIC, shutdown of multiple organs, especially the kidneys are very susceptible, renal failure, shock, and death. So this is why we match ABO. The D we match. So D is a protein instead of a carbohydrate. So we usually make IgG antibodies against this. They are much less likely to cause intravascular hemolysis, but they are very immunogenic. And there's a high enough percentage of the population, 15%, that does not express the D antigen in the US, that we could have a very significant problem if those people got randomly transfused, when 85% of their potential transfusions are going to be D positive and they could make an antibody. So we try to upfront match. So you can see this is our standard labeling, the International Society of Blood Transfusion labeling, which is used all over the world. So units are automatically labeled from the collection, wherever they're collected, with their AB and RH type. So we can very easily try to match someone's RH type up front. And if they don't express the RHD antigen, we can give them RHD antigen negative blood to prevent them from making an antibody. So usually you have to be exposed to foreign red cells. These are not naturally occurring antibodies. There's not anything on the surface of bacteria or other things we might get exposed to. So less than 0.5% of the population will have an anti-D in the US. So mostly, like I said, we're trying to prevent the antibody from being made. And it's primarily not because of transfusion, because usually we would only mismatch in an emergency, and hopefully people don't have repeat emergencies. The real problem here is that this antibody can cross the placenta. So if the mother is Rh negative, and there's an 85% chance, right, that her baby is Rh positive because the father of the child is Rh positive, then an immunizing event can be blood coming from the baby into mom's circulation. But an immunizing event could also be us transfusing Rhd positive blood. And then that can later be a problem for every subsequent pregnancy, that they can develop hemolytic disease of the fetus and newborn, which can be very severe and can lead to intrauterine demise. So this is more something that we do that's preventative, primarily for pregnancies. So you can see, ideally, if we take our ABO and our Rh compatibility together, then O negative, right, which doesn't have A or B antigen and doesn't have the Rhd, those red blood cells, which are the black check marks, would be compatible with every other blood type. And if we wanted to transfuse plasma or platelets, then our AB donor, who doesn't have either antibody and also doesn't express Rh, in case there might be some contaminating red cells in there, then that person would be compatible for plasma and platelets to every other donor. But AB negative people are 1%. So we can't expect 1% of the population to supply these products to a much larger percent of the population that comes in traumas or with a need of emergency transfusion. And of course, you know, this is 1% of the entire population. A very small part of our entire population actually donates. And so most of the time, the chance of having contaminating red cells is extremely low. In platelets, we know that, you know, it's less than 0.1 mils typically, if there's any in there at all. So usually we don't do the ideal situation according to this. And because we think the risk of contaminating red cells is so extremely low, we do actually give Rh positive plasma and platelets to Rh negative people. All right, Dr. Kniep's up.
So this core strategies for scarce resource situations is also from Minnesota. And so we're going to go through all of these ideas one at a time. Prepare is going to be taking pre-event actions to minimize resource scarcity. Substitute, use an essentially equivalent device, drug, or personnel. Adapt, use a device, drug, or personnel that is not equivalent but will provide sufficient care. Conserve, use less of the resource by lowering the dose or changing utilization practice. Reuse, so reuse after, of course, appropriate disinfection or sterilization, items that would normally be potentially single use, or reallocate, restrict, or prioritize use of resources to those patients with a better prognosis or greater need. So we'll go through these one at a time and show how they apply or don't apply to the blood bank. So prepare. So blood products, most of the blood products we have are allogeneic. They are for any recipient. We do, on very special occasions, have directed, where someone donates for a specific recipient, or autologous, where someone donates to themselves. Whole blood is the original blood product, and so that's where someone donates whole blood, and then we can manufacture that to derive our blood products. So we do a soft spin to give us our red cells and our platelet-rich plasma. And then we do a hard spin to get a platelet pellet And then we are able to pull off the plasma, and then we also have our platelet product. So this is going to separate our antibodies and antigens. So transfusion guidelines. So these are evidence-based and is a collaboration between the blood bank and clinical departments within the hospital. This tries to balance individual patient need with facility need, because we don't want to be giving all the blood products to a single patient and then not able to help other patients. But we also want to balance the need for transfusion with the risk of a transfusion reaction. So we prospectively review orders of all plasma, platelets, and cryoprecipitate. And so I've just included the platelets. So if these are the criteria, if it meets these criteria, it is on it. The platelet order is automatically approved and does not need to be reviewed by an attending, fellow, or resident. If it's outside guidelines, that is going to get brought to one of us. We will look up the patient information, give the clinical team a call, and have a discussion on what the clinical situation is that would require transfusion of blood products outside guidelines, the hospital guidelines. Multiple suppliers. So Vitalant and American Red Cross are the two biggest blood suppliers for University of Colorado Hospital. We also are able to get some products from Garth Blood Center, which is with Poudre Valley, and also Children's Hospital, Colorado. Unlike Children's and Poudre Valley, we do not have a donor center, so we are entirely dependent on Vitalant and the Red Cross for most of our blood products. And that is why we have multiple suppliers. If one of our suppliers is not able to meet a need, that need still exists, and we still need to get those products for somewhere for our patient. Garth and Children's, though generally that's used for an emergency. If we are short platelets, maybe we might be able to get a platelet or two, or we can also help them if they have some inventory that is short dated. We are a large volume center, and so we would be able to help get that transfused before it expires, because we do not want to waste or discard any blood products if we can help it at all. Inventory management. So we have standing orders with Vitalant, Red Cross, and Garth for blood products and for the blood components, and also whole blood. We try and balance supply with wastage, and that is why we have a optimal inventory and also a minimum inventory. And these are based off of medium usage. If we also look at the frequency of emergently ordering. So if we are emergently ordering quite a bit, we need to adjust our standing order and or our minimum inventory level. We also take part in inventory rotation. So as part of the UC Health system, we have many other hospitals in our system that are smaller and don't do the same transfusion volume that we do. So if they have a short date platelet, short date red cell, they can send it to us, and there's a good chance that we'll be able to get that transfused before it expires. Again, we're trying to be good stewards of the blood supply. However, for us, there's not anybody that we can really send it to, so we have to have pretty tight control over our inventory and not over order, which that's how the optimal and minimal inventory levels help with that. So this is an example of a new hospital. So they had set up inventory for their O-pos, O-neg, A-pos, and A negative. And then over a period of 8 months, the discards were recorded. And as you can see, there were quite a few, an unacceptable level of red cell discards. So that led the blood bank medical director to change the standing inventory for the hospital, because they were just not, with a maximum of 12 transfusions a day and a median of 2, the inventory they had that was just going to sit on the shelf and possibly expire. So as you can see later on, after the inventory adjustments, much less red cells were expired, which is good. Nobody wants to discard things or waste things that are given by donors. We try our best to get that transfused any way we can. Supply updates. So our suppliers will routinely send us emails about changes in inventory status. And for things that are critical or immediate, we will get a phone call. This is very nice because this allows us to pass this information on, like if there's going to be a platelet shortage and Vitalant, say, has very low inventory on platelets. We need to know that so that we can contact the anesthesia charge. The anesthesia charge is then going to look at the OR schedule for that day and triage different, some elective surgeries may need to be canceled. If it's a surgery that can get by without platelet transfusion, maybe that can still go on. But in the end, that's going to be their decision. The anesthesia charge is going to communicate with the other anesthesiologists and surgeons and make a decision, but they can't make that decision if they don't have that information. And so we try and let them know as soon as we know, because once the surgery has started, we have to support that surgery. It's much easier to prevent that surgery from starting, because once it does, we have to support that team. We also communicate with high usage departments, as I mentioned, the OR, but also trauma. So this is a bulletin that was sent out by AABB. So they're not only do suppliers, but AABB sends out about national inventory. And so this is something that we keep up to date on and are constantly adjusting our ordering based on what we need versus what is potentially available, and then passing that on to clinical teams. So known or predictable decreases in blood supply. So this may surprise some people, but holidays actually cause decreases in blood supply. Why is that? Well, people are spending time with their families, they're traveling, they're not at donor centers. And on the holiday, generally donor centers are closed. So holidays such as Thanksgiving or the week between Christmas and New Year's, those tend to be holidays that cause significant potential decreases in blood product availability. And generally that happens afterward, particularly with platelets. Platelets have a 5-day expiration. And so if the last day of donation is the Wednesday before Thanksgiving, and then nobody donates Thursday, Friday, early next week is when platelet inventory potentially gets tight. The donor centers will offer incentives that they know that this is a time when people are less inclined to come in and donate, and so they will offer incentives such as gift cards or a t-shirt quilt. Everybody needs one of those. So another predictable decrease in supply is summer. And that's because during summer, people go on vacation. So if you're on vacation, you're not going to be donating. The other thing is school is out. And so school blood drives aren't taking place. And so that can decrease the available inventory also. When Vitalant has computer downtimes or software upgrades, they let us know ahead of time that something is going to go down at 3 a.m. Saturday morning, potentially be down for 4 or 5 hours and then come back up. If we know about that ahead of time, we can somewhat increase our inventory just so that we don't have to order during that time period, because that's going to result in a delay, because they're not going to have their computers available, and so they would have to issue things on downtime. So now we can't, because of expiration times, we don't want to increase inventory too much, but we do want to be able to still meet the need despite that change in the supply.
Okay, so substitution is, replacing with something that's considered essentially equivalent. So the problem with blood products is there are not many things that are equivalent. So when we do informed consent, right, we have to tell people what the alternatives are. So in informed consent for transfusion, right, there really isn't a substitute for red blood cells. You could try, if people aren't severely anemic, to do other things to treat their anemia, right? So give them erythropoietin, give them iron, but there isn't really a substitute for red cell transfusion. Instead of plasma and cryo, you can give people clotting factor concentrates, which are just more highly treated or highly purified clotting factors from human plasma. And then there really is no substitute for platelets. There's not even a good alternative for platelets. So there are two different ways that people can donate blood products in this country. So if you donate a component, that is when you go to a blood donor center. You're a volunteer, you don't get paid. You might get an incentive, but it's considered that the incentive shouldn't be enough to make people feel like it's worth lying on their donor questionnaire in order to get that incentive. So typically they're not worth more than $25. So it might be a t-shirt, an umbrella, or they'll go up to a max of about $25. Or they'll enter you in a drawing, right? So it's sort of a lottery type of thing, but they can't be paid. And so this is how we make our blood components that we've been talking about. The other option is you can go to a plasma donor center, and these are paid donors, usually in the US. But the reason they can be paid is because the process of making these derivatives includes chemicals and filters that can pretty much decrease any infectious disease risk. So even if people are dishonest on their questionnaire and there is an infectious disease there, or they have an infectious disease risk, it will almost definitely be removed because of the processing. So they have very, very, very low infectious disease risk. So they're basically handed out as a drug, not usually as a blood product. So this is where we get a lot of our purified proteins. And we also get our purified clotting factors, most of them, which could potentially, right, be an alternative. It's not really, it's not fully a substitute, because like plasma has all of the clotting factors, right, all 13 of them. Whereas here, you're never going to get all the clotting factors, right? You're limited. And the cost isn't usually much higher. So it's higher cost and it has very limited factors, but it is the closest thing we have to a good substitute. All right, so we're going to look at a few cases. So this is a 29-year-old woman, and she came in having had a few days of non-bloody diarrhea, nausea, and vomiting. She recently traveled to Vietnam. She had a fever, really low oxygen saturation. She was actually passing out while they were trying to take her history during her H&P. And they did her CBC and found that her hemoglobin was 2.6. So if you remember back to Dr. Kniep's chart, 2.6 hemoglobin means you have like a day or two to live if you don't get transfused red blood cells. But in her case, right, she had a very strong warm autoantibody. It was so strong, it interfered with all of our testing. We weren't even able to determine what her blood type was. And we weren't sure if she had other antibodies under there. It was very hard to work around. No red cell units were compatible. And so, we can't leave someone with a hemoglobin of 2.6. So we're going to have to give out units that are incompatible, right? So Ed Snyder, who works at Yale, when I was, new to the blood banking community, he gave a talk and he said, giving fully compatible blood to a dead patient is not a success. So sometimes you just you give out blood with a big sticker on it that's labeled incompatible, but it's still the best thing for the patient because you can't leave them with a hemoglobin of 2.6. But another option, right? Lots of people are trying to work on creating a laboratory, figure out a way to create sort of universally compatible red cells, right? Chop off or don't produce the ABO antigen, don't produce a lot of the other antigens, or be the version that is the most common in the population. We haven't gotten there yet, but we do have hemoglobin. So we have some blood substitutes. Primarily, they are bovine hemoglobin based, that you can get oxygen carrying capacity from the hemoglobin, but it's not red cell, right? So even though these are called blood substitutes, I would really say they are red blood cell substitutes because they do not provide clotting factors. They do not provide anything like platelet function. So they're not like whole blood. They function as hemoglobin, but they are free floating hemoglobin. They have a lot of side effects. And basically the FDA has at the moment approved none of them. So as you can see over here, they were not approved, or one was approved and then withdrawn, or some of them are approved in different countries. So, you know, if you were really afraid of further hemolysis from red cells, or really, you know, unsure, we would love to have another option rather than giving incompatible red cells. We don't have a good one now. We have a couple of times for patients who are Jehovah's Witnesses who would not accept transfusion. We have gotten in HemoPure to give them. It's a problem because it's difficult to get it, right? It's only currently approved in South Africa, and I think they also added Russia. So it's difficult to get. It's not approved. We don't have it on the shelf. There's going to be a delay. It also is free-floating hemoglobin. So it's more stable than our hemoglobin. It doesn't interfere as much, but it turns the plasma red, which interferes with a lot of our lab testing. And the only way you can currently get it is by asking the FDA for a special dispensation under compassionate use. So you have to fill out this form. The physician has to say, yes, you know, I think that this is worthwhile. And then you have to tell the FDA a lot of information. And they also decide that this is an immediate life-threatening condition. Given the situation, there's no other good option. There is also not a current study that the person could be enrolled in. And so you can see they do approve. So usually it's a few hundred, right? Usually it's about 100, slightly less or slightly more than 100 a year. And you can see there were 6,000 in 2020, and that is because of convalescent plasma for COVID, which proved to not work as well as we hoped it would, but that is why this bar is so high. It was that one special blood product in desperation in early treatment of COVID when we didn't have any other good options. But most of the time it's predominantly for this red cell substitute, and it's just, you know, about 100 to 200 a year. All right, so our next patient has aplastic anemia. So her bone marrow just isn't working well at all, and she needs red cell and platelet transfusions weekly. But she keeps having transfusion reactions. She keeps having an allergic transfusion reaction. We tried pre-medicating her with antihistamine, and she still has the reaction. And so if people have repeated significant reactions, then we try to remove what they may be reacting to in the blood product, which is usually the plasma protein. So you can wash platelets and wash red blood cells to remove those plasma proteins. And that's considered, you know, the best way to make sure that you won't have another transfusion reaction. But it takes over an hour to receive the platelets. Platelets are prima donnas and they don't like to be shaken up or messed with too much. So you lose up to 30% of the platelets in the product. They don't work as well, they don't aggregate, and they expire in 4 hours. So this is a really hard process to do successfully. So an alternative that we could use is to, rather than completely removing the plasma from the platelets, we could decrease the amount of plasma in the platelets. And so the substitute would be platelets in a platelet additive solution. So several companies have developed platelet additive solutions, and you can see what's in them. Basically, a lot of the same stuff that's in our plasma, phosphate and citrate as an anticoagulant, sodium chloride, but we can replace 60 to 70% of the plasma in the platelet unit. And so for a lot of patients, just decreasing the amount of plasma they get exposed to can decrease or eliminate their allergic transfusion reactions. And this is what worked for this patient. So it's much easier to order in these PAS platelets, but only one of our suppliers makes these, right? The other one does not. Okay, so conserve. So we talked about especially, right, O negative red cells and AB plasma. Right, there are only 7% of the donors are blood type O negative, and only 4% of donors are blood type AB. So if we have someone come in as a trauma, and we have, they're significantly bleeding, we have no idea what their blood type is, but we need to immediately start transfusing them. Ideally, what we would like to do is to give them the universally compatible red cells, which is O neg, and the universally compatible plasma, which is AB. But, right, because they are a very small percent of the population, the O neg and the AB, and we have a lot of massive transfusion protocols that are called every day, right? We have 2.6 massive transfusions a day at University Hospital. And you can see we set up a lot of units, and we end up transfusing usually slightly less than half of the units that we send out. But it's still, several hundred units. And so we have to do something else to conserve these uncommon products for the patients who really, really need them. So, right, we talked about, we do need to give O red cells, but as far as the RH is matching that's usually a preventive for people to not make an NIB who might become pregnant. So we usually try to give that to children and women who are not likely to be of childbearing age. So the cutoff will differ from place to place. Less than 55, less than 50, right? But it's usually right around 50 to 55. So if a man or a woman who we know is over 55 comes in as a trauma or needs transfusion with unknown blood type, we give them ORH positive. There's about a 25 to 40% chance that they will make an anti-D. So just because you get D positive blood doesn't mean that you're definitely going to make an RHD antibody. But it should only be a problem in the future if they have to be emergently transfused again, which we hope that not too many people have to be repeatedly emergently transfused. And then also if people, need more than 10 red blood cells, even if we know their blood type is O negative and they are young, we have to conserve those. We can't give all of our O negatives out to one person, and then we have 5 other people in the hospital that we have no O negatives for, so we have to give them O positive. So now we've immunized potentially 5 people instead of 1 person. So if people really get massively transfused more than 10 red cells, we will switch them to RH positive. Plasma, again, ideally we would give AB, but that's only 4% of the donors. So we give A plasma emergently because that's 40% of our donors. A plasma is automatically compatible with blood type A and O. So it's going to be compatible with 85% of our patients. And if we're transfusing O red cells, right, it's compatible with the red cells that we're emergently transfusing. So we're sort of creating a compatibility. It doesn't really matter if it's Rh positive or negative, since, as we said, there's minimal amounts of red cells in plasma. So you can see this is just what someone did to show, right? This is what most of our platelets and plasma look like. No hint of pink whatsoever. Red blood cells are like red food coloring. The tiniest amount will make it look red. So this is 1 ml, and you can see it is completely red. Even half a mil, or a small percentage of a mil of red blood cells in this unit would make it pink. So since most of our products, most of our plasma and platelet products look like this, we don't expect there to be any red cell contamination that we would have to worry about de-immunization. And remember, anti-D is not naturally occurring, and we test all of our donors for unexpected antibodies. And if they have antibodies, we don't use that plasma. So we don't expect there to be an antibody either. So this has been shown to be a safe practice, and it's a good balance for individual care versus providing adequate products to everyone. And then platelets, we usually transfuse any type just because they have such a short expiration. We typically transfuse them based on when they're going to expire in most situations. So this is just an example of when we had a pretty unexpected and very, very dire decrease in our supply. So this was during the Omicron surge in December to January of 2022. And basically, we didn't have donors coming in because a whole bunch of people were sick with Omicron. The blood, collection agencies didn't have a lot of their coworkers because they were also out sick with Omicron. So you can see this is the worst blood shortage in over a decade, according to the Red Cross. And they were offering, in order to try to get donors who were healthy and could to come in, right? They actually teamed up with the NFL to offer a very good incentive of potentially winning a trip to the Super Bowl. And so that's what they did as a press release, but what they sent out in a letter to their customers, to our hospital, was that basically they have no reserve inventory. So, right, usually we have our standard inventory, and if we have an emergency, we can order, 20 extra units from them. But they basically said, we have nothing, right? We are keeping no reserve. We are giving everything to you. So if you need more, don't talk to us, talk to your neighboring hospitals. Basically, you're going to have to share amongst each other. And you also need to, right, inform your hospital, as Dr. Kniep talked about, to adjust your operations, to postpone surgeries, right, to conserve as much product as you can. So this is one thing that we did, is we basically, because ONEGs are always in short supply, right, we usually switch after 10, but we actually said, okay, right, in females, we're going to switch after 8 Rh negs. If you need more than that, we're going to have to switch you to Rh positive. And in males, after 5. So we do, this was a temporary deviation for a month, and then we went back to our standard practice. Adapt. So adapt is when you have to do something completely different that is not considered a substitute. So for example, you might want, one of the things they suggest, in several different protocols, is to do things to increase blood donation. So one of the things that the FDA did because of COVID is they actually had been considering changing their rules about donation for risk of HIV transmission. And so they basically said, we are putting this out earlier than we intended to, but we have already been looking at this very carefully. And usually when they put out a draft guidance, they put it out for comment, and then you can't implement it yet, right? So they put the draft out, people comment on it, and then several months later, they will come out based on those comments with a final guidance, and then you can follow it. But they said you can actually implement the changes that are in this draft, because we've looked at it carefully. Other countries have already done this, and we really need more donors to come in. So it used to be a 12-month deferral for many of these HIV risk events, and they changed it to a 3-month deferral to try to get more donors. All right, so right, we need more donors. That's one thing to work on. Another thing where we can have problems, right, is if to really label and release products, they all have to have infectious disease testing. So you have to hold on to the product. Usually they do testing overnight, and then this is Creative Testing Solutions, CTS. They do the donor testing for over 90% of the blood products in this country. So you can see both Vitalant and Red Cross and many other donor centers use them. And basically, in this case, CTS had an upgrade. So they upgraded their testing platform, and it didn't work. So they have 5 laboratories, and they tried to upgrade in all of their 5 laboratories at the same time. And it didn't work, and they had glitches and problems in all of their 5 laboratories. It went on, you can see, for over 3 weeks. And so basically we had all this product, right? Vitalant said, we have ample product on our shelves, but we can't label it and send it out to you because we don't have confirmation of appropriate donor testing results. So one thing that we had to consider, right, because platelets have the shortest half-life, they were the thing we were running out of first, or the shortest shelf life. And so we actually considered maybe filling out this document for emergency release, which is basically when we say we need product and we think the benefit versus risk ratio is that we're willing to take something that hasn't completely met the criteria, which in this case would be hasn't been proven through testing to be negative. But luckily we have this process called pathogen inactivation, which can, basically kill all viruses and bacteria in platelets. So we said if we do have to do this, right, if we do have to accept platelets but don't have their full testing complete yet, we want to accept the pathogen inactivated platelets because we know that even if there is something in there, it probably has been nullified. So yeah, this was a problem that went on for about 6 weeks because they just were trying to catch up first on platelets, then on the thing that it has the next shortest half-life, then on the thing that has the next shortest expiration date, and completely unexpected. So we have a 37-year-old woman with thrombocytopenia due to TTP. And so the preferred treatment for TTP is plasma exchange with plasma. So we often exchange people because it's an antibody problem. So we remove their antibody, and then we also give them the Adam TS13 that they're missing, that their antibody is against. But her blood type is AB, which we said is only 4%, and our AB plasma is always in short supply. And doing a full plasma exchange takes about 20 units. And so basically, right, I said to them, right, a full plasma exchange like today is going to be 22 units, and we only have 50 units on the shelf. So you're going to get today and tomorrow, and then we're not going to have enough for a full plasma exchange. We contacted our supplier about their reserve, and they only have 28 units. And so basically, right, this usually, can take several days, a week or more of daily plasma exchanges. So I said, we're going to have to do something. And I think the best thing is to, based on this evidence, replace part of that plasma with albumin. So they'll still get plasma. They'll still get a replacement of much of their Adam TS13, but we're going to have to exchange number of days that we can do this for the amount of replacement that they get each day. And so we did do that, and it worked well, as several publications have shown. All right, and then this is just a patient, for time I'm going to skip through, but this is a patient who needed very rare platelets. She had antibodies to platelets that made her very, very hard to match. When we gave her appropriate platelets, she responded. But if we just gave her a random platelet off the shelf, we couldn't get her to respond. And so we basically had to talk to the clinical team to say, right, she has all these antibodies. She has very few matches. Giving her random platelets is basically a waste because the antibody is going to attach and they're going to be removed from circulation almost immediately. So, right, she's on anticoagulation because of a line. Can the line be removed? Can we then decrease her platelet goal? Can we put her on a medication that stabilizes clot formation? Like, what else can we do? Because we just can't supply her with enough platelets. We asked Vitalant, our main blood supplier, that you can see they have over 120 donation centers all across the country. And even out of all of their donors, they could only find 6 good matches for her. So we said there's just no way that 6 people can supply enough platelets for her everyday need. So we're going to have to change her platelet threshold, right? So they agreed, right? They couldn't take her line out. They could lower her platelet threshold and maybe lower it more after they reassessed her clot. They did put her on a stabilizer, right? So sometimes, and we also talked to benign heme, right? So multi-team, and they said, well, actually, if you increase hemoglobin, it can help low platelet counts to function better. So we actually upped her hemoglobin threshold and gave her more red cell transfusions than we usually would to help with her platelet issues. All right, Dr. Kniep.
So reuse. So one of the reuse techniques that we use is called cell salvage. And so this is an intraoperative process where we basically suction the blood from the surgical field. The blood is then filtered and washed, and then it is transfused back into the patient. And this reduces the number of red cell units needed for surgery. And in the last quarter, the use of cell salvage saved us 786 red cell units. Now you can see which types of surgeries tend to be bigger users of cell salvage, because it's not applicable for everything. If there's the potential for contamination of the surgical field, then we're not going to be able to do this, but we do try and use it whenever we can. And while these patients still need transfusion support, particularly platelets and plasma, we're able to recycle their red cells, which then saves red cell units for other patients. Another thing that we do is ensure proper storage temperature. So when we issue units, if they're not used, they can be returned to the blood bank, but we have to ensure that they are in temperature, otherwise they have to be discarded. So we have safety views that we put on the red cells, and this tells us whether the temperature of the unit exceeded the storage temperature and then has to be discarded. And so for single units, we can put those in or for units, we can put them in validated coolers. We can use a tube system or place them in a remote refrigerator. Now, if we tube a single unit somewhere, the clinical team has about 20 minutes to decide whether or not they're going to transfuse that. If they are not, they need to return it to us so that we get it back before it goes out of temperature and can put that back into inventory. If it's in a cooler, the coolers are validated for 7 hours. And so as long as they keep it in the cooler with the lid closed, they can keep that in the operating room or in the ICU room for quite some time, and it'll still maintain the temperature. We can do aliquots where we pull small doses off of a single unit for a neonate. We do this sterilely. And then even though this would be considered a potentially a low volume unit, we can issue that to an adult patient. Reallocate. So for the trauma case with the teenager with the gunshot wound, this is just the surgical note basically saying that after doing all these interventions, after talking to the family, they decided that they were not going, this was not a situation that they could save this patient. And so they came to the conclusion of minimizing care and transfusion. Very quickly, some places opt for more objective ways to do this, such as point system for triage, or they actually have a triage team or triage committee. We do not have that. We communicate directly with the clinical teams, but depending on the hospital size and the situation, one system may work better for the others. And with that, we are finished. Sorry for running a little bit late.
Thank you very much. Uncolink from Geisinger has a lot of questions, and I'm going to ask you guys to connect offline. But in general, they have more conservative. They're pointing out that you have very liberal platelet guidelines, and they had standard procedures in COVID-19 that they hung on to after COVID-19. I'm asking the question, why did you have restrictions and then go back to former practices? Why not just hang on to the more conservative not less liberal restrictions?
What type of restrictions are we talking about? Like the switching of the to RH positive?
They did a number of things that I'm not going to be able to.
Okay.
But how was that decision made between you and the other physicians in the hospital? How was the decision made to the standard for platelet guidelines and then switching back?
Never switched our platelet.
We didn't switch our platelet guidelines during.
Okay, so I'm confusing the conversation with Geisinger. So there's a lot of clinical questions at University of Illinois, and Geisinger do some things a little differently. So I'm going to see if you can connect offline. So
Sure.
Because I thought I would confuse the question, and I did. So
No
thank
worries.
you very much, and look forward to seeing everyone April 13th for a discussion of ethical issues in a post-war Roe nation. Thank you very much.
Thank you, Jackie.
David.